Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. This episode is part of our series on sleep and mental health. The content here is for educational purposes only and does not constitute medical advice, diagnosis, or a prescription. Clinical decisions should be based on individual patient assessment and established professional guidelines. After decades of sedating the brain into unconsciousness, sleep medicine finally asked a different question. What if insomnia is not a failure to shut down, but a failure to time sleep correctly? That question led to melatonin agonists. Melatonin is not a sleeping pill. It is a circadian signal. Secreted by the pineal gland in response to darkness, melatonin tells the brain that night has arrived. It does not force sleep. It permits it. That distinction matters. Melatonin agonists work upstream of sedation. They don't suppress cortical activity. They align the internal clock. And because of that, their strengths and their limitations are very specific. Melatonin receptor agonists represent a non-habit-forming class of sleep medications that mimic the body's natural sleep signal hormones without the cognitive impairment or dependency risks associated with GABA-acting agents. There's no appreciable abuse potential, no dependence, and no withdrawal syndrome. It does not cause respiratory depression. It does not impair cognition or balance. Now let's review some melatonin receptor agonists. Ramelteon or Rozerem is indicated for insomnia, specifically sleep onset or difficulty falling asleep. Ramelteon selectively targets MT1 and MT2 receptors in the suprachiasmatic nucleus or SCN. This is the brain's master circadian clock. MT1 signaling facilitates sleep onset. MT2 signaling shifts circadian phase. Together, they help the brain recognize when sleep should occur. Dosed at 8 milligrams nightly, it has a relatively short half-life of about 1 to 2 hours. But its effect is not about duration. It is about signaling. That's why it is primarily a sleep onset agent, not a sleep maintenance drug. Tasimelteon or Hetlioz is indicated for non-24-hour sleep-wake disorder, common in blind individuals. It is also used in jet lag symptoms following transatlantic travel. It is an agonist at MT1, which mediates sleepiness, and MT2, which synchronizes the circadian clock. Agomelatine or Valdoxan is approved for major depressive disorder with sleep disturbance. It is a potent MT1, MT2 agonist combined with serotonin 2C antagonism, which increases dopamine and norepinephrine in the frontal cortex. Agomelatine is used extensively in Europe and Australia, but it is not currently FDA approved in the US. To summarize melatonin receptor agonists, MT1 receptors binding primarily regulates the induction of sleep, which shortens sleep latency. MT2 receptors binding primarily regulates circadian phase shifting, realigning the sleep-wake cycle. Now let's talk about melatonin itself. Over-the-counter melatonin supplements vary wildly in dose and purity. Many products contain far more melatonin than physiologic levels, sometimes 10 to 20 times higher. And higher doses don't work better. In fact, they can fragment sleep, worsen vivid dreams, and blunt the circadian signal through receptor desensitization. Unlike over-the-counter melatonin, prescription agents have a much higher affinity for the receptors and a more predictable pharmacokinetic profile, making them effective for long-term use in patients where stimulants or dependency are a concern. But melatonin agonists don't work like sedatives, and that's where expectations go wrong. They do not knock patients out. They do not overcome hyperarousal. They do not work well if someone is lying in bed scrolling, ruminating, or fighting the clock. If insomnia is driven by conditioned arousal, anxiety, or learned wakefulness, melatonin agonists will underperform. Where they shine is circadian misalignment. From a psychiatric perspective, this is a critical distinction. Many patients with depression or ADHD do not lack sleep drive. They lack circadian stability. Their brains do not reliably recognize night. In those cases, melatonin agonists can help re-anchor the rhythm without worsening cognition or mood. From a systems perspective, melatonin agonists represent a philosophical shift in sleep medicine. They acknowledge that sleep is regulated, not suppressed. That timing, light exposure, and behavior matter as much as neurotransmitters. But they are not standalone solution for chronic insomnia. Melatonin agonists work best when paired with behavioral alignment, consistent wake times, light management, and reduced nighttime arousal. Without that foundation, they become another pill that did not work, when in reality, they were never meant to overpower the system. In the next episode, we will move into the newest class of sleep medications, agents that target wakefulness itself rather than sedation or circadian timing. These drugs reflect where modern sleep medicine is heading: precision, specificity, and fewer downstream costs. Because the future of sleep treatment is not about shutting the brain off, it is about teaching it when to rest. Thank you for listening. If you found this episode useful, please share it with colleagues across disciplines. See you next time.